Hi, I'm Dr. John Martin. I'm recording a series of videos based on common questions women have asked me in my many years of practice. This video will be on inductions.
Doctor, doctor.
As with many videos I record, I would suggest you have conversations with your physician or midwife about the process that they use for induction and reasons they use. These are just my reasons and how I practice and how I take care of my patients. I think one of the first things that is important to understand when talking about induction is we still have never figured out what the exact cause or trigger is for a woman to go into labor. We can mimic contractions with medications. We can, ripen and prepare the cervix through medication, but we still do not know how to exactly trigger a woman to go into labor. All the advances we've made in science, but we haven't figured that one out. A couple things to clarify before we get started. One, before there's an induction, there is a great degree of unpredictability of how your body will react to the induction and how long it will take. That's where having a thorough discussion with your physician or midwife is important. Some basic things to start with. There's something called a Bishop score, based on your exam of your cervix, and there's really 5 findings on your cervix that physicians use to calculate the Bishop score. One is the position of your cervix, whether it's mid, anterior, posterior, whether it's in the front, the middle, or the back. Consistency, whether it's soft or firm or kind of intermediate. The station of the baby's head in relation to your pubic bones, -1, -2, -3. Those are things that your physician can explain to you. The dilation of your cervix, whether you're 1, 2, 3, or 4 centimeters dilated, and the thinning of your cervix, what we call effacement. 100% thin is all the way thin, 50% is half, so that's called effacement. And then of course your porousness, and that's P-A-R-O-U-S, porousness. I don't know if that's a word, I just invented it, but it's a nulliparous patient is somebody who's never had a baby before, and a multiparous patient is somebody who's had vaginal deliveries before. Those are all important facts in kind of determining how your induction will go. The unpredictability of it, length of time, doctors can kind of give you an estimate on how long it'll go based on your Bishop score, so really to have that discussion. Techniques of induction, there's several. One is using prostaglandins for a cervix that isn't very favorable, let's say a Bishop score less than 5 or whatever your physician might tell you, but one that's not very dilated or effaced or soft and more posterior. So the cervical ripening agents really come in 2 forms, but they're all a medicine called prostaglandin, which softens and effaces your cervix or prepares your cervix for cervical ripening. There's different names. There's one called Cytotec, which is a little pill that's placed in the vagina. There's Cervidil, there's Prepidil, and those are all different ways to do it. The other way to get a cervix ready is some people use a balloon placement. They'll literally put a balloon into your cervix and then inflate it with fluid to open and dilate your cervix. For women who've had babies before or who are dilated, you can jump right to Pitocin. Pitocin will give you the stronger contractions. I think the 2 things that I always warn my patients about with induction is number 1, the length of time. And I try to give them a good measure of what that'll be. And then that the pain is increased with an induction, but not for the reasons you may think. It's not that the medicines we use are bad and evil. In fact, I always say Pitocin is analogous to a medication your own body makes called oxytocin. And we know that's what gets triggered when a woman goes into labor. And Pitocin is just a chemical analog to that. But what is different from naturally going into labor versus Pitocin-induced labor is when you naturally go into labor, you kind of gradually build up to the very strongest contractions. So your body adjusts and accommodates to that pain over time, so it doesn't feel as bad when you're at the top. Well, with induction, we're using these medicines to push you along the way more quickly so you don't have that transition time. So you go from 0 to 60. So you're still at 60. It's still the top speed, but it feels very different because you don't have that adjustment and accommodation phase. And I think that's super important to remember that's why it's more painful. But what I always tell my patients is don't fear pain. If you ask for medication, you will get medication. If you ask for epidural, you'll get epidural. So always have that discussion with your physician or your midwife as well. The last point I think I want to make with induction is there's kind of a misconception out there that inductions increase the risk of cesarean section. Actually, there was a very big study published last year in 2019 called the ARRIVE, ARRIVE trial that showed that inducing a nulliparous woman, somebody who's not had a baby before, had no increased risk of waiting for them to naturally go into labor, of undergoing a cesarean section. In fact, the risk of cesarean section was a little bit lower in the women who were induced at 39 weeks. I always tell people, to me, the biggest thing is it proved that induction does not increase your risk of cesarean section. So remember that. The two things that I emphasize to patients are length of time and pain, but like I said, don't fear pain because we will take care of your pain with proper and appropriate pain medication and even epidurals if you need to. One more thing that I wanted to bring up was the length of time. I always tell people it's hard for me to predict how long it'll take you to go from 0 or 1 or 2 centimeters to 6 centimeters, which is really the definition of active labor. But once you're 6 centimeters, you go pretty quickly. So that length of time that's the unpredictable part of it is that 0 or 1 to 6 centimeters. It can take 5 hours, it can take 15 hours. But typically, once you're 6 centimeters, you'll move pretty quickly. So those are two important caveats. The ARRIVE trial and the length of time from 0 to 6 centimeters will really determine the length of time of the whole process. I hope this has been helpful. If it has been, follow me on Instagram, share it with your friends. Also follow me on Facebook, like these, and I will continue to do more videos because I hope these are helpful and informative for patients just based off of my many years of experience. Thank you very much. Be safe, be kind, and be well.
Doctor, doctor, you gotta help me, please.